So good morning, everybody. Welcome to Sleep Medicine Grand Rounds. It's my pleasure to introduce Dr. Ian Neeland. Dr. Neeland is the UH Director for Cardiovascular Prevention, the UH Translation Science Unit, and the Cinema Program for HHVI, and Associate Professor of Medicine at Case Western Reserve University School of Medicine here in Cleveland. He is a general and preventive cardiologist with special expertise in obesity, diabetes, and prevention of cardiovascular disease. Dr. Neeland is very active in clinical and translational studies with funding from the NIH and industry. He's published 140 scholarly articles to date and delivered a number of national, international, and regionally invited lectures. He is a fellow of the American Heart Association and the American College of Cardiology, and serves on several national committees with the American Heart Association. And today he's going to be talking to us about cardiometabolic therapy for obstructive sleep apnea. So Ian, thanks for being here.
Thank you. Thanks for having me. I was wondering if these sleep meetings, they start late, maybe like 10 o'clock. So people
You would think, yeah.
Walk the walk, we talk the talk. So thank you very much for having me. I think I spoke here a few years ago as well. At that time it was on Zoom, I believe. So it's nice to see people in person and meet some of the sleep division. So happy to be here. These are my disclosures. So the objectives today, per CME, to identify two classes of cardiometabolic pharmacotherapy with evidence for beneficial effects on obstructive sleep apnea. Describe the potential mechanisms underlying those effects of OSA, and then name at least one current trial, and that's a little bit of a plug, testing the effect of a cardiometabolic pharmacotherapy on obstructive sleep apnea. So hopefully at the end we'll be able to do all of those things. So just kind of set the stage. I know I'm a cardiologist, and you guys are the experts for sure, but not too long ago, sleep health became one of what we call life's essential 8. There was life's simple 7, the 7 health behaviors or metrics that one should try to maintain from the beginning of life all the way through adulthood to try to reduce the risk for cardiovascular events and to keep maintain cardiovascular health. And then not too long ago in 2022, sleep became one of those. Now became from the simple 7 to the essential 8. And as you know, sleep health really is very multidimensional. There's a lot of overlapping components and aspects to it, from duration to timing, regularity, like chronicity, how efficient the sleep is, how well the sleep is enjoyed, and then how much it impacts daytime alertness and function. And obviously, recent evidence suggests that sleep metrics add independent predictive value for cardiovascular disease. Some of the data, which I'll go over here today, as above and beyond the original 7 metrics. And there really, though, is a paucity of evidence, with interventional studies looking at sleep on cardiovascular disease incidence, but there are certainly several lines of epidemiological support to show its connection with cardiovascular health. As you know, sleep is a broad construct, and sleep deficiency is defined by the NIH as kind of the construct they want us to think about in terms of multiple aspects, looking at several areas of adverse sleep consequences. So whether it be insufficient sleep duration or sleeping out of sync with the body's natural rhythm, that circadian sleep mismatch, not getting all the stages of sleep, so impaired sleep architecture, and then obviously sleep disorders, which we see clinically, of which obstructive sleep apnea is probably the most common, and then you have insomnia and others as well. Now, sleep deficiency is certainly very prevalent, as you know. These are data just from this past year's heart disease and stroke statistics, which show that the percentage of the population reporting less than 7 hours of sleep is at a maximum was 40%, and at the very least about a quarter of individuals who report that. So that's a fair amount of sleep deficiency if you define it by the amount of sleep that you get per night. And certainly, like many other cardiovascular, cardiometabolic adverse events, there's certainly a health disparity there with underrepresented minorities. You can see that non-Hispanic Black patients report the most sleep deficiency, the least amount of sleep, and then you can see here other races as well. So there's certainly a lot to be done, even as of last year, in terms of narrowing that gap and improving sleep efficiency overall. And one of the reasons why it's so important is because obstructive sleep apnea, as one of these sleep disorders, is certainly common and critical, especially when it comes to cardiometabolic diseases. So first of all, it's very common, 17% of the total population. Those data are, relatively old by now. I'm sure it may be more. And among those with obesity, 40 to 70% of those. And it's a critical risk factor for not just obesity, but also diabetes, cardiovascular disease, stroke, as I'll show you. And so it really is important that, cardiologists like myself and sleep physicians like yourself, we get together and we try to tackle this together. Really, it's a multidisciplinary disorder. Now, here are some of the data, epidemiologic data, showing that OSA is a risk factor for cardiovascular, cardiometabolic problems. This is a study now from 2005 from the Neeland Journal with Yagi, who's a collaborator of mine in research, and he showed that indeed, the greater the AHI, the greater the likelihood of stroke or death, with a hazard ratio over 3 for those with severe OSA. You can see here the Kaplan-Meier curves that there's clearly a reduced probability of event-free survival in patients with obstructive sleep apnea. And when you took a look at this in a model, it turns out that one of the strongest or highest hazards for TIA, stroke, or death beyond age, diabetes, smoking, the things you would expect, is obstructive sleep apnea actually has the highest hazard ratio for that outcome. So that's very sobering. And if you look also similarly at coronary events or cardiovascular death, you see a similar trend. Beyond the traditional risk factors, sleep apnea is strongly related, even under adjustment, with adverse cardiac events. And so that's very established and very clear. What's less clear is how that happens, right? So we know that sleep and cardiometabolic disease is on this continuum, this bi-directional relationship, whereas obesity and dysfunctional adiposity, for example, visceral adipose tissue, ectopic fat, increases fat deposition throughout the body, but often in areas where it shouldn't be. That's why it's called ectopic, such as the upper airway and the tongue, and that decreases airway caliber, leading to obstructive sleep apnea from an anatomic standpoint. At the same time, you have acute sleep restriction and currently short sleep duration, which are in turn linked to increasing obesity, right? Staying up late, abnormal behaviors, health, not exercising, insulin resistance, and then the cycle just keeps feeding on itself. So there are several lines of evidence pointing to this bidirectional relationship. First of all, laboratory studies of patients with obstructive sleep apnea showed very clearly impaired glucose tolerance and insulin release, and then decreased leptin levels, which is a satiety hormone, elevated ghrelin levels, which is a I want to eat hormone, and increased hunger and appetite. And then from an epidemiologic standpoint, we know that short sleep duration increases risk for development of type 2 diabetes, and sleep apnea increases the risk for type 2 diabetes. And so what you have is a bidirectional hypothesis, such that you have obesity and type 2 diabetes leading to increased fat mass, insulin resistance, and adverse adipokines, leading to weight-dependent and physiology-dependent sleep apnea that leads back to intermittent hypoxia, sleep fragmentation, and that cycle just keeps on feeding itself. And so the question is, how do we break the cycle? How do we impact and identify the mechanisms underlying this and really address that as opposed to just addressing the anatomic problem, all right, at the end stage? So we know that weight loss certainly helps. There are several lines of evidence for that. Here are 2 different studies. The Wisconsin study, which was a couple decades old, showing that the mean change in AHI, the reduction in AHI, is strongly related to a change or reduction in body weight. You can see here that if someone loses a significant amount of weight, which we call over 10%, then the AHI changes to almost -3, whereas if someone gains that amount of weight, the AHI can go up substantially as well, all the way to 5 or 6. And from the Sleep Ahead study, which was a sub-study of the Look Ahead trial, which was a trial of intensive lifestyle therapy versus diabetes usual education in patients with obesity, overweight, and type 2 diabetes, which itself showed that weight loss through a lifestyle was very beneficial for symptoms, surrogate markers, but did not have any impact on cardiovascular events. But in the sub-study did show that losing weight with this lifestyle intervention, which even a modest weight loss, about 8% after 1 year in the trial, showed that apnea-hypopnea index did decrease in that intensive lifestyle intervention ILI group, that group in the black bars. And that was, again, correlated with weight loss. So the greater the weight lost, the greater reduction in apnea-hypopnea index. And so that's very clear. And I think what came from those studies, what we call obesity and the rule of tens for obstructive sleep apnea. Has anyone ever heard of this before? Rule of tens? Okay. All right, good. So basically we can say is a 10% weight gain predicted a 32% increase in apnea index. On the flip side, a 10% weight loss predicted a 26% reduction in apnea index, and that was pretty consistent. And then a 10% increase in weight predicted a 6-fold increase in the odds of developing moderate to severe obstructive sleep apnea. So clearly, obesity and body fat is a key aspect to intervene upon to reduce risk for sleep apnea. Now, right now, obviously, we have CPAP as the main or only method of treatment, obviously stenting open the airway and improving airflow. And the anatomic pathogenesis of sleep obstructive apnea, we understand that there's a concept of critical closing pressure, where there's a balance or imbalance in the promotion of airway patency vis-a-vis the pharyngeal dilator muscle contraction and lung volume. On the other side, promotion of airway collapse through fat deposition, potentially the anatomic jaw, and negative pressure inspiration, and that leads to either collapse or patency at some critical closing pressure, which is usually different than the normal in someone with severe obesity or ectopic fat, and that leads to either a highly collapsible upper airway with a peak crit is greater than +2, or a stable upper airway, and that's the anatomic understanding of how sleep apnea works. Obviously, this is known to you guys. And we know that CPAP, therefore, as a treatment for that, certainly may improve outcomes. If obstructive sleep apnea is related to increased cardiovascular events, so it would stand to reason that CPAP would be related to less. And indeed, in this study, showed that at least those with severe obstructive sleep apnea had who have a great amount of events. If you put those people on CPAP, you can see that the number of events mimics those who just have mild OSA, snores, and controls. So certainly CPAP works, at least in terms of these cumulative cardiovascular events. The issue is that, and everyone knows this, that CPAP certainly is not enough. So first of all, at the very least, it's not a disease-modifying therapy. It's not changing the inputs, the things that are leading to obstructive sleep apnea at all. It's really just treating, the end result. It stents open the upper airway, attenuates sleep-related sequelae, but doesn't address the underlying pathophysiology and the traits that drive obstructive sleep apnea. And not only that, but as you know, 50% of patients with obstructive sleep apnea adhere to CPAP therapy, and the other half are just not able to tolerate it, don't do it. Many times in clinic, I'll have patients who I've seen you guys that have been prescribed CPAP, and they can't tolerate it, they don't want it, and they don't use it. And so really the kind of holy grail, I think, for obstructive sleep apnea is, can we find other therapies that address the physiologic problem, and potentially pharmacologic therapies, which probably have more adherence than CPAP, that target those biologic pathways and can improve outcomes and adherence, especially in reduced cardiovascular risk. So it's known, I guess more recently, that not just anatomy plays a role in obstructive sleep apnea, but physiologic traits contribute as well. And it turns out that about half of patients have obstructive sleep apnea from abnormal physiologic traits as opposed to the anatomic problem. And so these include oversensitive ventilatory control with instability, that's called high loop gain, but low respiratory arousal threshold, and then the inability to dilate and stiffen the pharyngeal muscles in response to ventilatory drive, or poor muscle response. And those three non-anatomical traits actually show that about 56% of patients of obstructive sleep apnea are due to those non-anatomic causes, which CPAP may or may not help. Right? So there's a whole, subset of obstructive sleep apnea patients where they're not even using CPAP. And even if they do, they might have physiologic traits that are not being addressed with the CPAP for their OSA. So there's a lot to be done here. Here we go. Okay, and these patients do not get obstructive sleep apnea for the same reason. So there really is a need for better therapy and new targets that address both the anatomic and physiologic traits of sleep disruption. So currently recommended non-CPAP therapies include weight loss, which certainly works, but it's very difficult to achieve, although getting better with our GLP-1 receptor agonists, oral appliances, certainly surgery, and there are some pharmacotherapies out there that I think have been tried, acetazolamide, for example, but they're definitely not standard of care and not utilized all the time. And then there's these non-anatomical traits, right, like the oversensitive ventilatory control system, poor pharyngeal muscle response, and low arousal threshold, which you can use certain things like supplemental oxygen, nerve stimulation, certain drugs, and sedatives and hypnotics. But those are all, again, not addressing the underlying physiology that leads to sleep apnea. And so what alternative or experimental therapies, pharmacotherapies can we use? So moving now into pharmacotherapy beyond CPAP, which was the title of the talk, I want to talk about two classes of medications. I'm sure you're familiar to some degree with both of them, the SGLT2 inhibitors and the GLP-1 receptor agonists. These are two drugs that continue to have additional indications from the FDA. They both started out as anti-diabetes medications and have morphed into cardiovascular drugs, weight loss drugs, kidney drugs. And so really they have multiple different indications and benefits across the physiologic system. And it makes sense, right? Because from a cardiometabolic standpoint, all of those things are tied together. From a physiologic idea, the kidneys, the heart, the body fat, everything is tied together. And so these two classes, I'll go into some detail into how potentially they can be used for sleep apnea treatment. So first, just to let you know the most up-to-date evidence on cardiovascular and kidney effects in these medications. So SGLT2 inhibitors were discovered, they're come from a tree, they're called flozins, and they found out that it reduces glycemia by about 1%, the A1C. Now, if you look at the overall milieu of different anti-diabetes medications out there, it's relatively weak, right? So insulin certainly is much more powerful. Sulfonylureas are more powerful, although they have a lot of problems to them, and the other ones as well. So it's a relatively modest reduction in glycemia. It also reduces body weight by about 2 to 3 kilograms. There's data from the empagliflozin trials. But even though it's focused and its physiology is focused on the kidney and increasing glycosuria and reducing reabsorption of glucose in the kidney, they found that it reduces MACE, major adverse cardiovascular events, by 11%. It reduces cardiovascular death or heart failure hospitalizations by 23%, and that's actually both heart failure with reduced ejection fraction and preserved ejection fraction. And reduces CKD progression. That means people progressing to 40% reduction in GFR, to end-stage kidney disease, kidney failure, by 45%. So it is now a workhorse for not just diabetes, cardiovascular disease, and kidney disease, as well as heart failure. On the other side, GLP-1 receptor agonists, which really kind of were developed and have kind of evolved in the same time period, it's more powerful with glycemic reduction. In fact, it's usually recommended as first line for glycemic control in patients with concomitant obesity. Reduces A1C by 2%. Body weight by about 50% if you take all GLPs. But at the top level, tirzepatide and retatrutide can show things like 25-30% body weight. So at the level of bariatric surgery now. They also reduce major adverse cardiovascular events by 14% and heart failure hospitalizations by 11% and CKD progression by 21%. So there are lots of benefits to these medications. And the question is, understanding that the common pathophysiology between cardiovascular and cardiometabolic disease and obstructive sleep apnea, can they improve symptoms and outcomes in sleep apnea? So let's first talk about the SGLT2 inhibitors. So from an anatomic and physiologic standpoint, there may be a rationale to apply this for OSA patients. From an anatomic standpoint, they reduce adiposity. There's data that shows that it can actually reduce body fat distribution in different areas. And then certainly because the way that it works is through causing glycosuria and shifting of fluid, right? Water goes to sugar. You can have fluid shifts potentially through the body, where you may shift fluid away from the upper area downwards, and that reduces some of the airway collapse. From a physiologic standpoint, there's a lot involved in terms of rhythm, arrhythmia, the cellular level, renal sodium handling, tubular feedback is another one that's come out to be a big one, increasing oxygen efficiency, delivery to tissues, as well as potentially non-anatomic traits, but has not yet been studied in the physiologic traits. So here's some of the lines of evidence that we have that SGLT2 inhibitors can impact anatomic traits leading to OSA. So this is comes from the EMPA-REG outcome study, which was a big cardiovascular registration trial in which 2 doses of empagliflozin, 10 and 25, were compared against placebo in patients with established cardiovascular disease and type 2 diabetes. And what it shows is that both body weight and waist circumference at the end of the trial, week 164, was significantly reduced compared to placebo. And so certainly we know that it impacts adiposity directly. We also, as I mentioned, could reduce rostral to caudal fluid shifts. We know that in obstructive sleep apnea versus those without, the upper airway has more pharyngeal wall edema, as you can see here, comparing panel A to panel B, and these arbitrary units of wall edema. And then there's a correlation between the overnight decrease in leg fluid volume and the apnea-hypopnea index, such that more fluid shifts from the legs to the head result in more apneic events. So the idea would be that if you can reduce through diuresis or shifting of fluid from the head to the legs or out of the body, that may actually improve the sleep apnea symptoms in AHI as well. So another line of potential evidence for this drug. And then finally, this is a study that I did when I was at UT Southwestern, looking at the effect of SGLT2 inhibition on how the liver handles glucose and glyconeogenesis. And so what we did was we gave patients either empagliflozin or placebo. We measured their baseline enrichment of a labeled, non-radioactive labeling in glucose, such that the idea is that if most of their glycerol that goes into glucose comes from the liver, it's going to be labeled, the stuff that we gave them, because it goes through the GI system. Whereas if it's coming from their adipose tissue, so if their visceral adipose tissue is feeding the glycerol and feeding the liver to become hyperglycemic, it's going to be unlabeled. And so we compared the labeled versus unlabeled and found that in placebo, there was no difference between baseline and follow-up, whereas with those treated with empagliflozin, there was more enrichment in the labeled glucose than the unlabeled, such that the less shift from the body's adipose tissue, which was an indirect line of evidence suggesting that SGLT2 inhibitors can actually impact, without weight loss alone, impact adipose tissue physiology, less shunting of triglycerides to the liver, and causing hepatosteatosis and hypoglycemia and diabetes. And so again, potentially this drug has adipose physiology impacts as well. And then probably the most interesting line of evidence comes from two studies, post-hoc analyses from 2 large studies. The first one was the EMPA-REG outcome trial, which is what I mentioned earlier. So what we looked at in this study was the incidence of new onset sleep apnea by report, by physician report. And this was, again, a couple thousand people or 6,000 people who were randomized to empagliflozin, either 10 or 25 or placebo, and we looked at the difference in new onset sleep apnea. You can see here that there was a 52% reduction in new onset sleep apnea in those who were treated with empagliflozin in the trial. Right. So now, first of all, the event rates were relatively low. There were 50 total events in this study. Okay. Second of all, this was a post hoc analysis. It was a pre-specified endpoint in terms of reporting, but they didn't do sleep studies. They didn't do baseline sleep studies. They didn't exclude people with sleep apnea at baseline. It was all through self-report. But it's very intriguing evidence, at least, that treatment with an SGLT2 inhibitor can actually impact sleep apnea in terms of incidence and onset. We then did the same study in the Virtus CV trial, which was a trial of a different SGLT2 inhibitor called ertugliflozin, which in a very similar population, this population was a little bit mixed in terms of primary and secondary prevention for cardiovascular disease. But interestingly, we found an almost identical hazard ratio in terms of reducing new incidence of sleep apnea. With ertugliflozin versus placebo. And again, rates were relatively low, but these were certainly 2, very intriguing lines of evidence suggesting there may be something here, impacting sleep apnea. So when we looked at what mediated the effect of the SGLT2 inhibitor on sleep apnea, it turns out that if you look at the reduction in A1C, the improvement in blood pressure, the improvement in weight, and the increase in hematocrit, which is efficiency to oxygen to the tissues, only about 22% of the new onset sleep apnea was mediated, the reduction was mediated by those 4 aspects. So suggesting that there may be some other things that the SGLT2 inhibitors are doing, something off target, something we're not measuring, the basics that's there. And that really led this intriguing line of evidence to want to know what are the potential mechanisms underlying these effects. Are these effects real? Can we reduce severity of sleep apnea with SGLT2 inhibitors? What does it look like in terms of impact on anatomic and also non-anatomic physiologic traits? So that led to what's called the ADIPOSA study, and that's a study that I'm doing with Dr. Yagi out of Yale. It's a 2-center study. We're going to be recruiting patients with overweight and obesity, BMI of 25 to 40, with moderate to severe obstructive sleep apnea. So you have to have at least an AHI of 15 events per hour or more, and they got it with or without diabetes. And we're looking to do this here at UH as well as at Yale. We get 164 patients. And then randomize them to ortugluofloxacin, one of those we studied, plus usual care versus placebo. And then we want to then follow them for 6 months and assess all these potential mechanisms underlying the impact on OSA. So at baseline, we're going to be doing a very sophisticated home polysomnography with a Knox A1 device. Are you guys familiar with the Knox device? It's almost like a level, not level 3, what do they call it?
Level 3.
Level 3, okay, yeah, level 3 device. So, and there's an EEG array on the front as well, so that you get a lot of really good information. We're going to be doing 24-hour ambulatory blood pressure monitoring, structural MRI imaging of the entire body from neck to knee, and including the jaw and airway. Doing some biomarkers, validated sleep questionnaires, and as well as actigraphy to look at sleep and activity. We then do that at baseline, and we repeat it at 6 months. And the idea is to find out what is driving the impact of SGLT2 inhibitors on sleep apnea. So our conceptual framework and our hypothesis is that, one, does it drive and improve anatomic traits? So looking at neck and tongue fat, soft tissue structures, airway caliber, visceral and ectopic abdominal fat, PCRIT, and blood biomarkers of dysfunctional adiposity. Aim 2 is looking at non-anatomic physiologic traits, the ones I mentioned before. So we're going to be doing scoring with the Knox company and Sleep Solutions, so with Scott Sands, who's out of Boston, to look at these non-anatomic traits and the impact of SGLT2 inhibitors in this study. And then aim 3 is to find out how it impacts clinical markers, apnea-hypopnea index, hypoxia measures, sleep deficiency. And the idea is to see whether or not is the anatomic or the physiologic traits, or both, that mediate the impact of the clinical outcome. And so we're very excited about this study. We are going to be recruiting starting really in November for the first patient, first visit planned for January. So this is the shameless plug that I mentioned earlier. This is our study website. We're going to have posted flyers, rat cards in the sleep clinics. We're on the Trial Finder website, and this is Joe. And Joe is our study coordinator, and that's his information. And he may, if you guys are okay with it, reach out to you directly to see, screen your patients, see who may be interested, who may be eligible, and maybe come to a sleep clinic to try to, recruit. And really, I know it's very hard. Everyone always asks me the same thing, right? Can you please recruit for help recruit for our study? But this is such a really cool and interesting study that's funded by the NIH that I think that you guys will be super interested as well. So please, if you get an email from Joe, please don't hesitate to respond, and he'll make sure your patients get screened. And this is the rat card that we're going to have in the clinics, and that's our clinicaltrials.gov number and the information. So I'm really excited about this trial. It's a big study. You can imagine how many different phenotypes we're measuring and how detailed it is. And it's 2 centers. So it really is a really cool thing. Dr. Stroll is a co-investigator. Dr. Patil is also working with us as well. Okay. Let's move on now to GLP-1 receptor agonists and how these might impact OSA. So again, from an anatomic standpoint, it's actually a little more understandable how this can impact through adipose reduction and fluid shifts. But also physiology, many of the same physiologic traits that underlie SGLT2s, GLP-1s can impact as well. So what evidence do we have that GLP-1s can be helpful? So first of all, we know that weight loss is now very significant and substantial with these agents. And it's not just GLPs once, but a GLP, GIP, and triple agonist, GLP, GIP, and glucagon receptor agonist. So the companies keep coming up with these combinations to really push the envelope when it comes to weight loss reduction. You can see here with GIP GLP-1, which is tirzepatide, at the 15 milligram dose, you're talking about 22+% weight loss in a population of patients with overweight and obesity. And it turns out that 21% reduction across the board versus 3% in a trial. And then with the triple agonist, which is retatrutide, we're getting close to 25% weight loss. So again, this is really closing in on surgical weight loss, and doesn't have a lot of the consequences or potential long-term adverse events with surgery, although there are certainly plenty of issues to deal with for these medications, but they're very powerful, and they're coming out on the market very quickly. In terms of OSA, so there is evidence showing that a GLP-1 receptor agonist can, in patients with obesity and moderate severe OSA, reduce AHI. So this was a study of 359 patients where they were randomized to liraglutide 3.0, which is Saxenda, the same drug, versus placebo for 32 weeks. And these are people who didn't want to use CPAP. So at the baseline, they were 48 years old on average. The mean AHI was 49, BMI 39, and 3/4 were male. And at the end of the trial, the 32 weeks, those who were randomized to liraglutide had a reduction in AHI of -6.1 versus placebo. You can see here that on the top graph, the AHI reduced actually very early on. You can see that the curve separated within a couple of weeks. These drugs work very rapidly. Weight loss can be seen within 4 weeks to 8 weeks, significant weight loss. And again, correlated with AHI reduction was weight loss. The more weight loss that existed, the greater AHI reduction. And that obviously is irrespective of the drug, right? So at least from this study, we know that from an anatomic standpoint, just weight loss alone is certainly related to reduction in AHI, although you can get a more robust weight loss with the GLP-1s. But this doesn't necessarily tell us the physiology changes. There's another trial that's being recruited for, it's called SURMOUNT OSA, which is in tirzepatide, that dual GLP-1 GIP. And this is a 52-week phase 3 trial to evaluate the efficacy and safety of tirzepatide in those with moderate severe obstructive sleep apnea and obesity. They're going to be stratified by baseline CPAP use. They're looking for about 500 participants, and it anticipates to finish the trial in March of next year. Okay, so to kind of round off this talk today, I want to talk about how potentially body fat modification can improve sleep deficiency in OSA beyond just weight loss alone. So there's data that visceral adipose tissue, that's the adipose tissue that's in and around the abdominal organs, that's not supposed to be there. The way that the body was designed to store excess triglycerides in adipose is through the subcutaneous department. But when the subcutaneous tissues are overwhelmed, they have a certain set point, there's a spillover into other tissues, and those tissues can go to the visceral compartment as well as to other organs where they don't belong. That's called ectopic fat, whether it be the heart, the skeletal muscle, the liver, and the pancreas, for example. And so we know that visceral adipose tissue is highly correlated with cumulative incidence of cardiovascular disease. You can see here in the left panel that the higher quartile of visceral fat, the higher incidence of CVD by about 2-fold. And we also know that reduction of visceral adipose tissue can occur with weight loss, especially through GLP-1 receptor agonism. This is a trial on the right that we did looking at the impact of liraglutide versus placebo on a background of exercise and diet with visceral adipose tissue loss. And this is a waterfall plot where those in blue were assigned to placebo, and about half lost visceral fat, half gained over the trial, and versus those on liraglutide, almost everybody lost significant visceral fat. And we know that we can image this, we can take a look at this, and it's important to be able to image it because often you cannot discern someone who has a lot of visceral fat from very little visceral fat with anthropometrics alone. So for example, these are two patients with identical BMIs and identical waist circumference, and visceral adipose tissue on the person on the right is 9 liters versus 2 liters on the left. Okay, so it's a major difference. And what underlies that? Well, you can see, for example, that the guy on the left, look at his legs, right? Very muscular body frame. So BMI is very inaccurate when it comes to how much body fat you have. right, in an individual person. And so even waist circumference in that setting wasn't informative. And so we do that excess visceral fat is a risk factor for cardiovascular disease, independent of anthropometrics, BMI, and waist circumference. Ectopic fat is another one that's importantly and correlated, and that we do have interventions, lifestyle, pharmacologic, and surgical treatments for weight loss can have greater impact on reducing visceral ectopic fat relative to body weight. Beyond the body fat, which you see here on the right, these are different examples of segmentation of visceral adipose tissue in pink, of subcutaneous in blue, as well as leg fat tissue and liver tissue. But the tongue and the airway has a lot of structures, muscular and fat structures. So we can measure submental fat, tongue fat, airways, patency, neck fat, internal and subcutaneous. And so all these can actually impact the anatomic and physiologic traits of OSA. Now, how does this happen? As I mentioned, when you have increased caloric intake and decreased energy expenditure at a simple level, you have a positive energy balance, excess triglycerides. Those excess triglycerides are shunted through into the body and try to store in the subcutaneous depot. What happens, though, is that there can be lipid overflow into organs that the fat does not belong, and that tissue can become inflamed. And that inflamed adipose tissue increases lipolysis, increasing free fatty acid release into the body. And that imbalance between loading and export of lipids results in ectopic fat accumulation and adverse consequences thereof. So we do know that these GLP-1 receptor agonists, semaglutide, that's Ozempic or Wegovy, reduces tongue fat. So in a small cohort of women with living with obesity, they were randomized to semaglutide versus placebo for 16 weeks. You can see that there was a significant reduction in tongue fat in those with semaglutide versus an increase in tongue fat on those with placebo. So, and kind of a cool picture here with the yellow adipose being tongue fat and on the red tongue. So we're going to be doing this in our trial as well. We have one of the world's experts in tongue fat on our study out of UPenn. So we're very excited for that. Just a couple lines of other evidence showing that visceral adipose tissue is highly related to cardiometabolic disease. So this is a trial that, or not a trial, it's a study we did in the Dallas Heart Study, looking at the relationship between increasing visceral fat and the incidence of diabetes. And as you can see, that certainly visceral adipose tissue is highly related to incident diabetes in patients living with obesity, whereas subcutaneous fat is not related. And so they're showing, again, a dichotomy between where fat and where it's at and its impact on disease. And indeed, it was higher related to incident diabetes, and chi-square value was 17, which was higher than many of the other risk factors, such as fasting glucose, systolic blood pressure, and family history. And then similarly, I mentioned this study looking at the impact of visceral adipose tissue, the relationship with incident CVD in the Dallas Heart Study, and about a twofold increase. And again, when you put this into a multivariable model, it turns out that visceral fat is highly related to CVD, whereas abdominal subcutaneous and liver fat were neutral, there was no relationship, and lower body subcutaneous fat, that's the fat in the hips and the buttocks, appear to be protective, reduced, or associated with a reduced incidence of CVD. And the thought there is that that's where the fat is supposed to be stored, in the hips and buttocks. And so if people can store it there and increase it there, then it buffers the ectopic deposition, it buffers from the visceral department, and doesn't allow the fat to become hypertrophic and inflamed and impact the cardiometabolic system. So next time you see, you're thinking about where fat should be at, it really should be hips and buttocks. So it's a good thing from a cardiovascular standpoint. There's also fat in the pericardium, and there's some evidence to show that there's a relationship between pericardial fat and coronary heart disease, myocardial infarction, and stroke. These data came out of the Framingham Heart Study, so that's another area to potentially look at, and certainly maybe one area to think about, how arrhythmia might play in with obstructive sleep apnea, right? There's a relationship between arrhythmia, heart rate variability, things like that, because the pericardium can be constrained by the fat, and that can impact the hemodynamics of the heart. And then muscle fat is also another independent marker that's actually independent of visceral fat, subcutaneous fat, liver fat. And see here that these are three individuals with identical age, identical BMI, identical visceral fat, but there's a big graded difference between how much muscle fat infiltration they have in their thigh skeletal muscles. And again, this can be related to poor function, to sarcopenia, falls, frailty, and again, may play into the sleep deficiency syndrome. We'll have to see. Now, in terms of the treatment intensity of obesity, we know that we want to go from non-pharmacologic treatments to physical activity, caloric restriction. For those who have a higher risk and more comorbidity, we look at pharmacologic therapy. And then obviously for the highest risk individuals who need the most weight loss, because it's most robust, will be surgical weight loss through gastric sleeve and gastric bypass. And indeed, bariatric surgery can also improve obstructive sleep apnea. This is a systematic review and meta-analysis of 19 studies, although only one was a randomized controlled trial, that showed that bariatric surgery was associated with a mean difference of minus 30 events in AHI, which I think is pretty substantial, right? But again, these people are at the highest amount of obesity, severe class 3 obesity. So many of them have severe OSA, but the improvement can be substantial in that population. So again, if a patient can't get on a GLP-1 receptor agonist, can't lose weight, can't do CPAP, then surgery is an option for OSA. Okay, so in summary, how much time am I doing on time? Oh, pretty good. Okay, so summary: sleep deficiency is epidemic in the U.S. Overlaps with rising rates of obesity and type 2 diabetes, especially among underrepresented minorities, obviously, and it can have a major impact on cardiometabolic health outcomes. We do need new targets for sleep deficiency that address the underlying physiology, both the anatomic and physiologic traits that lead to obstructive sleep apnea and sleep disruption. We went over 2 classes of medications, the SMGR inhibitors and GLP-1 receptor agonists, that actually may impact either or both the anatomic and physiologic traits. I showed you some evidence that SMGR inhibitors reduce new onset investigator-reported sleep apnea in 2 cardiovascular outcomes trials, and that the effect was only partially attributable to conventional OSA risk factors, and also put a plug in for our study where we'll be testing this directly. GLP-1 receptor agonists, which are all the rage in the news, I'm sure you've seen them. They reduce AHI in patients with obesity and moderate severe OSA, can also reduce tongue fat. And finally, bariatric surgery is gaining interest as a potential therapy for OSA in those who don't have any other options or means to improve it. So I think that's it for today, and happy to take any questions. Thank you.
Well, a couple here in the chat. Yeah. Might even maybe go to the Hollywood scripts, maybe. Just leave the presentation mode.
Okay.
Let's see if there are people that are.
Stop share.
Yeah, Ian, that was great. I get one question. I guess is it clear with these medications? Clearly reduces obesity, but do we know that it clearly reduces visceral fat versus subcutaneous fat, or is it kind of both compartments that are affected?
Yeah, so for both SGLT2 inhibitors and GLP-1s, we know that it would directly reduce visceral fat. The GLP is a lot more sound evidence. There was a trial that we did when I was at UP Southwestern. We randomized people to liraglutide 3.0, Saxenda versus placebo, on a background of diet and exercise, and found that visceral fat was reduced by about 16% compared to placebo, whereas weight was only about 5%. So there's a preferential reduction in visceral as opposed to subcutaneous and other. The 2 greatest compartments that were reduced was subvisceral and liver. Liver was 33% reduction. So they do attack, and then the reason for that partially is because there's more lipolysis, more active lipolysis in those tissues which are inflamed and active, and so they reduce. SGLT2 inhibitors, we have kind of more indirect lines of evidence. So there's the reduction in waist circumference, the reduction in visceral fat index is another study that we did, and then showing that it impacts the physiology of visceral fat vis-a-vis the liver and how it increases glyconeogenesis. So we have that as well. The real limitation to these, and the GLP-1s at least that's being addressed, is how can you measure visceral and ectopic fat directly? And you need MRI or CT to do so. And for many, many years, the trials were doing sub-studies in body fat distribution using DEXA, which is very crude and not able to really discern visceral fat. So now they're moving, like, for example, tirzepatide, the SURPASS program, is doing dedicated MRI sub-studies on vessel, liver, visceral fat. So they're doing a good job.
And out of curiosity, some people will say, neck fat is a form of, visceral adiposity or ectopic fat deposition. do these studies show that there's a disproportionate reduction in neck fat compared to other?
Well,
depots?
all the studies that I've been involved with, I never used neck fat because I never really thought about it until I got involved in this space, really. And so, there obviously is correlation with semaglutide, neck fat, weight loss, but this trial is going to be able to discern that. We're going to be doing body fat from neck to knee, visceral, liver, subcutaneous, muscle infiltration, muscle volumes, as well as all the neck tissues. And so we'll be able to see, at least from both an interventional standpoint and just generally, how the correlation goes.
Other questions here online?
This was a really fascinating talk, and thanks so much for presenting this. I couldn't help but think, listening to some of the data, we're assuming that there's roughly a 2-for-1 drop in AHI for every percentage decrease in BMI or weight, 20% for 10%. At the same time, we're looking at, SURMOUNT OSA using tirzepatide. We're expecting 25-30% reduction in BMI, maybe let's say 20-25% to be more conservative with that medication. I mean, does that mean that we're going to be looking at a 50% reduction in AHI on average when this study reads out? I'm just curious your take on that, and if so, I mean, my gut reaction is this is going to be first-line therapy for OSA. This is a real game changer.
Yeah, no, I agree. I mean, if you extrapolate the bariatric surgery data, right, it showed about a mean 30, not 30%, but a 30 reduction in AHI. So if you assume, let's say a baseline, we're talking people are in the 40s and 50s and severe OSA, then that's at least a 50% reduction in AHI. So I do think from at least that indirect evidence that we're looking at major reductions there. And I agree with you. GLP-1 receptor agonists, started as anti-hyperglycemic medications for diabetes. Then they moved on to weight loss. Then they're moving now on to heart failure. So in heart failure with preserved ejection fraction, body weight, diabetes, all the cardiometabolic comorbidities are intimately linked with HFpEF, heart failure preserved ejection fraction. And so now we have evidence from trials that SGLT2 inhibitors improve HFpEF. And now there's one called STEP Heart HFpEF, where it improves symptoms of HFpEF in patients with obesity as well. So what's going to be in the future is that for people with HFpEF, which is 50% of all heart failure nowadays, they're going to be treated with an SGLT2 inhibitor and a GLP-1 receptor agonist as first-line therapy. And many of those patients are going to have OSA, and that's going to be another treatment for that. So, the indications just keep on coming with these medications. It's fascinating. Kingman asked the question, what are the inclusion and exclusion criteria in general for the trial and whether on CPAP or not? So the patient has to be living with overweight or obesity, BMI of 25 to 40, have to have moderate to severe OSA, so that's an AHI of 15 or more, and can't be on CPAP or not be on CPAP. We're actually going to stratify by CPAP use as well as type 2 diabetes, so we'll be able to look at the relationships that we find on the drug in both subsets of groups, and so that's the basic inclusion exclusion. The only exclusion criteria really are, if you're already on one of those medications, or you're on a weight loss trial already, or you can't tolerate them, or you're contraindicated to the drug, or contraindicated to to being in the trial can't be on, for example, you just can't tolerate it, things like that. So when they're tested, when we do the testing phase, the baseline and at follow-up, they're going to be off CPAP for possibly up to a week. So it's going to be at the discretion, I think, of the individual patient and the PIs, but how long they should be off for, but at least probably a day or two to be on. So if they can't be off it at all, then we'll probably just test them, as much as we can off of it. But the idea is to take the CPAP out of the mix, at least for right there. Now, there's probably a little bit of legacy effect with some of these phenotypes in CPAP, which is why we want to stop it a little bit early. But for the vast majority of them, CPAP won't affect, many of the, at least the body fat, such, things like that right there, right then and there. So I think that's going to be what we're going to do. I think Sally has her hand up.
Yes, thank you. A fantastic talk, by the way, and wonderful work that you're doing. Thank you very much for sharing all this wonderful data. I guess my question is, in clinic, you mentioned, sort of that lower, sorry, my timer was going off, the lower body versus upper body in terms of fat distribution. There's been some studies I recall, sort of central adiposity, waist circumference indicating higher risk. And then you mentioned maybe waist circumference wasn't sort of risk stratification. So when we're thinking about risk stratification for patients in general, how do you measure adiposity currently in the clinic? What would you recommend besides an MRI?
Sorry, so yeah, the imaging is not available clinically right now. Unfortunately, I'm trying to get it here actually. But what we do have, you have BMI, okay, which is relatively crude. Waist circumference does contribute additional information beyond the BMI, certainly. But the problem with waist circumference is that at the very end of the day, the waist is just measuring waist size, and underlying that waist could be subcutaneous body fat or visceral body fat expanding the waist. So it's unclear which of those are. So it's better than BMI, but it's not as good as direct measurement of visceral and subcutaneous fat. But because we often, that's all we have, right? We have either BMI, and sometimes we have a waist tape in the clinic, and that's what we have. Now, the American Medical Association came out with a statement in June, that we need to go beyond the BMI in clinic. Right? Very few people have waist circumference in clinic. No one really measures it. And so there's a lot of reasons to go beyond the BMI, not the least of which is the crudeness and the inaccuracy of it, but also the BMI is tied to historical harm. It was developed predominantly in a white population. It was used for exclusion based on race and such. And so going beyond that, and they recommend some combination that you have of body fat distribution, body fat assessment through DEXA, for example, can be additionally helpful. If you have waist circumference, waist hip ratio, those are all factors that can be used. In the clinic, honestly, in a busy clinic, it's tough to do anything beyond the BMI. But if you can do waist circumference, that is the recommendation. It's the guideline recommendation as a class 2A evidence to use waist circumference to additionally risk stratify in patients with obesity.
Perfect, thank you. And I have already emailed one patient for your study, so I'm hoping that they will be interested. And then a second question, if you don't mind, do you have studies going on in children or adolescents? As you know, that's a growing population. I'm seeing a lot more diabetes and hypertension, unfortunately, in the children, in teenagers. Are there studies that you're aware of going on currently? I know there's one that's maybe approved for children, but I can't get it. Insurance won't cover it. So if there's ongoing studies, I'd love to hear about that.
Yeah, I don't know of any studies, certainly here, I'm not doing any studies in pediatrics. We do have the STEP teen study, which was semaglutide in adolescents that showed a reduction in body weight in the adolescent population. So it is, I believe it's FDA approved for that population now based upon that study. There are definitely pediatric studies going on as well as SGLT2 inhibitors. But there's none that I know of here at UH, but I can certainly look into that for you.
Thank you.
Okay, well, we have one more question, I think. Kingman wrote, then there are about 50% of those that the BMI range do not have OSA. Another feature of upper airway control is loss of OSA leading to upper airway instability. Could this factor be from white fat toxicity? Yes, we're going to be looking at that in the study, obviously correlating all the different phenotypes with each other to see what's underlying and driving the mechanism. I don't know any definite preclinical data showing the free fatty acid depositions affect respiratory control. So I have to look into that a little bit further. Kim, if you know of any data, please let us know. Suzanne has her hand up.
Yes. Hi, Dr. Neeland. I'm one of the sleep fellows. Two questions. So if people are rightly gaining weight around the hip butt region, can we assume that they're not, like, fat isn't going to the visceral area?
Yeah, everybody is different, right? Everyone has, a different combination that, or set point of where they store fat. Certainly those with large hips and buttocks, right? And small waist, then that's a pretty good indicator that most of the fat is in the subcutaneous depot and very little in the visceral. compartment. So certainly that's a positive phenotype. There are certain plenty of people like that. On the flip side, the people tend to be like, the middle-aged man with the big, overhanging belly and waist, with a relatively small lower, hip and buttocks and little legs. Then most of that's probably in the visceral compartment. So yeah, you can get it definitely from you get a sense. But again, BMI and waist circumference are the currently recommended metrics we have, although they're just anthropometric to measure. If you ever have a patient, we have another study going on, and I don't want to do too many studies because we want to make sure you guys don't get too overwhelmed. But we have a study called Body Real, and Body Real is for patients with overweight and obesity and with or without type 2 diabetes. The idea of Body Real is we do an MRI for them, and we give it to them the report, much like if you do a cardiac calcification report, right, coronary calcium score. If a person gets a report and a number and pictures, then that's much more impactful a lot of times to their behavior, their changes of lifestyle, and what they want to do. So we actually randomize people to the body fat report versus just telling them what they weigh, and then we see how that impacts their behavior, their perception of risk, surrogates through the MR. So that's another study called Body Real. So if you have patients who don't fit for our study for obstructive sleep apnea, then certainly this other study, there's a 50-50 chance they would get an MRI. So at least, if they're interested in doing that, that's a potential way to do it, through research.
Yeah, that's very interesting. My second question, your study testing the liraglutide, both groups had diet and exercise. So how did you define that?
So diet was based upon a 500 kilocalorie reduction in their baseline diet through dietary recall. So we assessed their baseline and reduced it. Physical exercise was guideline based exercise recommendations, 150 minutes a week of moderate intensity exercise. So and then counseling throughout the study to maintain those two.
Okay, great. Thank you. It was a great talk. The tongue fat, I never thought about fat in the tongue. So that was an interesting point. Thank you.
Yeah, it's fascinating. One last question I'll take. Kingman wrote, the drugs affect UP1. So energy expenditure. GLP-1s and GIPs themselves do not affect energy expenditure. And that's why they're trying to develop these additional peptides looking at glucagon receptor agonism. Glucagon receptor agonism actually may increase energy expenditure, potentially through UP1 as well. And so the drug retatrutide, which I showed one slide from, which was just presented at the, I think it was either ADA or ESC this past few months, that showed almost like a 25 or 26% weight loss. The triple agonism, GIP, GLP, and glucagon receptor. And that one's going to be a hot one. It's funny because Lilly's developing that, and Lilly also has tirzepatide. So they'll be, competing with themselves, but we'll see. A lot of people, I guarantee you, are going to switch from Wegovy or semaglutide to this new one when it comes out, because there's a plateau with these drugs. And a lot of people have plateaued, and there's also shortages. And so people are going to want to switch directly, and it's going to be quite a mess, I'll have to say. Competition. Yeah, exactly. All right. Well, thank you so much for having me. I really enjoyed coming.